Okay, so I'm making note of that. So I'm Gabby, one of the Jews. We're talking about the evidence behind the eFAST this morning. Special thanks to the education Sano team for their feedback and comments. And by the way, this is not like an EBM lecture. All right, so point of care ultrasound has had a significant impact on the evaluation and management of trauma patients, and it's readily available, reproducible, non-invasive, and super cost effective, as we know. Historically, the DPL, diagnostic peritoneal lavage, was done to detect teen peritoneum in trauma patients. While it's super sensitive and specific, it's very invasive with a complication rate somewhere around 1%. CT is currently the gold standard for diagnosing intra-abdominal injuries and is able to detect as little as 100 cc's of intraperitoneal fluid. CT has a sensitivity somewhere around 97 to 98% and a specificity of 97 to 99% for abdominal injuries. The FAST, the focus assessment with sonography and trauma, is an ultrasound protocol adopted in the US around the mid-90s to assess for hemoperitoneum and hemopericardium and blunt and penetrating trauma. It's allowed providers rapidly screen for injury at the bedside, allowing a quick assessment of patients too unstable for transport to CT. The FAST has since become a common initial screening in the majority of trauma centers across the US and worldwide. And currently all level 1 trauma centers in the US incorporate the FAST into the algorithms as does ATLS. And now, as of like 2004, the eFAST protocol has been adopted into their trauma algorithms as well. So during the 1990s, a large number of prospective studies were published reporting sensitivities of the FAST, somewhere between like 69 and 90%, with specificities ranging from 95 to 100% for detection of hemoperitoneum in patients with blunt abdominal trauma. And that's where the focus of like most of this information I'm giving you this morning is going to be. It's like on blunt abdominal trauma. However, a lot of these studies from the 90s were comparing FAST findings to patient outcomes and not CT findings. More modern studies place the sensitivity of the FAST within that range of 69 to 90%, but like a little bit on the lower end, so like the low 60s. But they use CT and operative findings as comparison standard. And penetrating abdominal trauma, reported sensitivity of the FAST exam ranges from 28 to 100%, but the specificity is very high, ranging from somewhere like 94 to 100%. This is a meta-analysis of 22 papers in the FAST exam that, among other things, was looking to assess the precision and accuracy of bedside imaging studies to identify intra-abdominal injuries in patients with blunt abdominal trauma. They included studies that compared FAST findings to reference standard like CT, DPL, laparotomy, autopsy, and or the patient's clinical course. They show that the FAST has a sensitivity of 82% and a specificity of 99%. Sensitivity and specificity were a little bit lower at 74 and 96% respectively, as you can see on the chart when I adjusted for publication bias. Additionally, they found that that positive FAST exam makes an intra-abdominal injury likely with a summary likelihood ratio of 69. Remember that a likelihood ratio greater than 10 suggests pretty strong evidence for something. A normal FAST result decreases the likelihood of an intra-abdominal injury with a summary LR 0.18. And remember that LR less than 0.1 suggests that something is highly unlikely. When the authors kind of stratified patients into hemodynamically unstable versus stable, they found that patients that were unstable may be more likely to have obvious FAST exam findings, identifying an intra-abdominal injury, which makes sense. For studies that included unstable patients, a positive FAST had a summary LR of 82, and those that excluded unstable patients had a summary LR of 36, a difference that was almost statistically significant. A negative FAST had a summary LR 0.16 for studies that included unstable patients, while studies that excluded them had a summary LR 0.3, which is not significant. As we know, the eFAST is indicated for blunt and/or penetrating abdominal trauma and undifferentiated shock and hypotension as part of the rush exam. It evaluates 3 potential spaces in the body: pericardial, pleural, and peritoneal for pathologic fluid. And the eFAST includes scans of the bilateral thorax to look for pneumo and hemothoraces. Just a quick mention about the probes used. The curvilinear or abdominal probe is used for the eFAST to avoid delays when switching between transducers. The phase array or cardiac probe is effective as well, but not really ideal for imaging the abdomen. And the abdominal probe actually allows for better penetration of the tissue in the abdominal cavity. The linear vascular probe is ideal for assessing pleural sliding, but again, you may not exactly take the time to switch this probe during a trauma. Just use the abdominal probe with the depth decreased. This is your subsiphoid view. Remember to, I'm not gonna like go in detail about each of the, how to obtain each of the images, because it's January, more or less everybody should be on the same page. But just for this view, just remember to increase your depth and hold the probe overhand so you can place it at a very shallow angle, almost parallel with the patient's chest. Penetrating trauma traditionally starts with this view to quickly rule out pericardial effusion and impending tamponade, for which is very sensitive. I forgot to include, there's an article on the POCUS Evidence Atlas about patients in traumatic arrest that underwent like resuscitative thoracotomy, and they're looking at the presence of pericardial effusion and cardiac motion. I would highly just recommend like glancing at that if you have the time. So this is the right upper quadrant view. Traditionally blunt trauma, it starts with this view, as this is one of the most sensitive regions to evaluate for free fluid. But people might switch it up depending on the mechanism of injury. It visualizes the patellorenal recess, aka Morrison's pouch, the hepatodiaphragmatic area, and the caudal edge of left liver lobe. It's super important to catch the liver edge when scanning the right upper quadrant. This retrospective study showed that the caudal liver edge / superior aspect of the right pericolic gutter is the most sensitive area for assessing free fluid in the intraperitoneal space, and not in Morrison's pouch as traditionally described. The authors of this study looked at 48 FAST scans confirmed positive by CT or in the OR. The right upper quadrant view they found had a sensitivity of 66%, and the area along the caudal edge of the left liver lobe was the most sensitive subquadrant with a sensitivity of 93%. The area around the liver edge they found was always positive when Morrison's pouch was positive, but the opposite was not true. However, the difference between sensitivity of Morrison's pouch and the liver edge was not statistically significant in this study. Their data kind of supports the premise that free fluid kind of ascends and accumulates in the right upper quadrant, as described in some prior radiology CT studies, by first moving around the caudal liver edge before ascending into Morrison's pouch. Additionally, as one mentioned, this study showed that the pelvic view had a sensitivity of 50%, and the left upper quadrant had a sensitivity of 35%. Let's see, and how much fluid can you actually detect in the right upper quadrant? This was a blinded prospective study done in 1995 that used a DPL as a model for intraperitoneal hemorrhage. Participants were attending physicians, residents in EM, radiology, and surgery who continuously scanned Morrison's pouch while DPL fluid was being infused into the patient. The mean volume of detection was 619 milliliters, which is quite a bit. Only 10% of their participants detected fluid volumes less than 400, and the overall sensitivity at 1 liter was 97%, which makes sense. It's a lot of fluid. So this is a left upper quadrant view. Be aware that free fluid more commonly appear between the spleen and the diaphragm, and that's because of the sphenorenal ligament that kind of blocks fluid from accumulating between the spleen and the kidney. This is your pelvic view. Yeah, so sweep, caudally, and cephalad to obtain complete views of the rectovesical space in men and the rectouterine and viscouterine pouches in women. These pouches are the most dependent recesses of the intraperitoneal cavity. And then sweeping the area in sagittal orientation allows for more sensitive assessment of the pouch of Douglas and vesicouterine pouch in women. While the pelvic region is the most dependent region in supine patients, it can be really sensitive for detecting free fluid. You can sometimes miss free fluid here due to difficulty in obtaining adequate images, especially when there's an empty bladder. You kind of lose your acoustic window in that case. There might be some bowel gas artifacts scattered in the image, or a posterior acoustic enhancement distal to a full bladder. And then just want to make note that gender differences have been shown to affect where free fluid will accumulate in the pelvis. In males, intraperitoneal free fluid accumulates around the posterior wall of the bladder, and in women, free fluid is seen posterior to the uterus, such as in this image in the pouch of Douglas. Small amounts of free fluid in young women of menstruating age can be normal in the absence of trauma, which can potentially complicate assessment of free fluid in this area. So women of reproductive age can have small amounts of free fluid up to 50 mils in the pouch of Douglas. It's considered physiologic. Amounts greater than that should be regarded as pathologic, especially in the setting of trauma. And then assuming no injury or some other pathologic condition, free fluid should not be found at the rectal vesicular space in men, so behind the bladder. This was a retrospective study that sought to determine the association of isolated pelvic free fluid with intra-abdominal injury in pregnant and non-pregnant women of reproductive age who were exposed to abdominal trauma. It was conducted at Level 1 Trauma Center between 1995 and 2002. Average age of the participants was 27 plus or minus 9 years. They had 2,319 patients total. Among the 1,991 non-pregnant and 328 pregnant, 208 and 23 had injuries respectively. The FAST was done by sonographers and interpreted by radiologists. And then pregnant patients did a limited scan of the uterus, which included looking at fetal heart rate, looking at the amniotic fluid, and then doing a limited study of the placenta. Patients were assigned to the 4 groups I have here on the slide, according to location of free fluid, detected by ultrasound. So it was either you had no free fluid, or group 1, either had pelvic free fluid, group 3 was just abdominal, and then group 4 was abdominal pelvic. And then ultrasound findings were compared with the results of CT, laparotomy, DPL, or the patient's clinical course. So as far as the results go, among the non-pregnant patients, groups 2, 3, and 4 had statistically significant higher injury rates compared to group 1. And that intuitively makes sense. More fluid, more injury. Group 2 had a lower, significantly lower injury frequency compared to group 3 and 4, where the rates were similar at 81.4 and 90.5% respectively. And then among pregnant patients, groups 2, 3, and 4 had significantly higher injury rates than group 1. Group 3 had a higher but not significant injury frequency compared to group 2. And then group 4 had a higher injury frequency compared to group 2 that was not significant. In reproductive age women with blunt abdominal trauma, ultrasound detection of free fluid in the abdomen alone, and both the abdomen and pelvis were isolated to pelvis associated with higher intra-abdominal injury rate, they found. Therefore, isolated free fluid in the pelvis should not necessarily be considered physiological in pregnant and non-pregnant women versus exposed blunt abdominal trauma. For example, in this image, this is a 45-year-old non-pregnant woman, exposed MVC, unrestrained, complaining of epigastric pain. Trace fluid was found in the cul-de-sac, as on the image, but there was no evidence of injury in CT, and nothing concerning during the patient's clinical course. This image is a 16-year-old non-pregnant female with exposed ejection from car, pinned under said car for 2 hours, complaining of belly pain. Small amount of fluid was found in the cul-de-sac. So on longitudinal view. CT showed free fluid in the abdomen and pelvis, and XLAP subsequently revealed tears of her colonex serosa. This is a 22-year-old female positive IUP status post MBC with what was determined to be physiologic free fluid. In the setting of blunt abdominal trauma, like I mentioned before, any trace free fluid in the pelvis on the FAST might indicate that the fluid is not physiological, given that women only have like an average of 50 cc's in the cul-de-sac. This prospective observational study was done to determine the average minimum volume of detectable intraperitoneal fluid with the pelvic view FAST exam in the setting of blunt abdominal trauma. They found that examiners were able to detect around 150 cc's of fluid infused during DPL. And 150 cc's is probably too much, and in the right context, it's pathologic. Be aware that in pregnant patients, small amounts of pelvic free fluid might be missed just due to the mass effect of the enlarging uterus. However, the FAST overall is still just as sensitive in pregnant as in non-pregnant patients, so you should still use it. Moving on to the lung, the extended part of the FAST protocol that was added in 2004. Ideally, the lung sono examined the patient supine and completely flat. Free air will accumulate anteriorly in that case. And then you want to scan at the patient's most superior position, most sensitive location being around the third or fourth intercostal space for most people. You'll want to look for the sliding artifact known as the ants marching sign that represents the visceral and parietal pleura kind of sliding against each other and represents the absence of pneumothorax. Be aware that if you see comet-tail artifacts, also called lung rockets or beelines, kind of shooting down, similar to what's shown here, that indicates the absence of pneumothorax as well. If the ants marching sign is not present, obviously you have a pneumothorax. This was an observational study published in 1995 using an ICU patient population. The study included 43 pneumothoraces confirmed by either chest X-ray or CT. The control group included 68 cases in which the absence of pneumothorax was confirmed on CT. All measurements were taken on the anterior chest wall with the patient's spine. Disappearance of lung sliding was observed in 100% of the 41 analyzable cases of pneumothorax versus 8.8% of the cases without pneumothorax. 2 cases in the study group weren't analyzable due to emphysema. In the study, sensitivity ultrasound for pneumothorax detection was 95.3%, specificity of 91%, and negative predictive value of 100%. And these results were statistically significant. This data suggests that if lung sliding is present, you can quickly rule out pneumothorax and move on to look for or address other causes of respiratory distress, if present, or continue on with your trauma survey. If you can't clearly see the ants marching sign, turn on M mode. Normal lung sliding creates a grainy artifact below the pearl line, known as a sandy beach or seashore sign. In pneumothorax, the resulting you get this like homogeneous image without that grainy artifact. It shows up as a barcode or stratosphere sign. Likewise, the presence of a lung point sign is very specific and virtually pathognomonic of a pneumothorax. A lung point represents the exact point where air begins to separate the parietal from the visceral pleura. Specificity for pneumothorax is improved if you catch on your image pleural sliding near the lung point, this is in this image. The absence of a lung point, however, does not rule out a pneumothorax. If you put on M mode to the lung point, you might be able to see the transition from sandy beach to barcode sign, specifically. This was a prospective study done to determine if the lung point sign allows for positive diagnosis of pneumothorax using bedside sono. The authors looked at 66 cases of pneumothorax and 233 without in an ICU patient population. Cases and controls were confirmed by CT. The lung point was not seen in any of the cases within the control group, but was observed in 44 out of 66 of the pneumothorax cases. And they determined that the lung point sign had an overall sensitivity of 66% and a specificity of 100%. Overall, bedside sono is very sensitive imaging modality for detecting pneumothoraces. Numerous studies have demonstrated that ultrasound is far more sensitive than chest X-ray and physical exam for diagnosing them, with specificities of 99%. Supine EP chest X-ray has poor sensitivity, as low as 36 to 40% in some studies for checking pneumothoraces. This is a systematic review of 4 prospective observational studies assessing the performance of EDOC's ability to detect pneumothorax in adult patients with blood trauma. They compared the sensitivity of bedside sono, it's by chest X-ray, and identifying pneumothoraces. They looked at a total of 606 patients and cases evaluated between 1965 and 2009. Pneumothorax was confirmed by CT or rush of air upon chest tube placement in unstable patients. So they found that ultrasound had a sensitivity of 86 to 90%, and a specificity of 97 to 100%, and chest X-ray had a sensitivity ranging from 20 to 75% and specificity of 100%. Over time, the FAST exam has been incorporated into ED decision-making in the form of this familiar algorithm, is specifically used for blunt trauma. Stratifies patients based on FAST findings and helps guide the next steps of their management. So, stable patient with a negative FAST, you want to repeat the FAST, obtain a CT, or observe. It kind of depends on your decision making. Same patient with a positive FAST goes to CT. Unstable patient with negative FAST, you want to repeat the FAST or send in the CT. An unstable same patient with a positive FAST goes to the OR. I would add here that a patient with a traumatic mechanism of injury with positive pulmonary findings of eFAST, pneumo or hemothorax, being placed chest tube. This was a prospective randomized controlled trial done during a 6-month period from 2002 to 2003 that looked to assess how the FAST exam affected OR to OR time in 217 patients with suspected torso trauma, not requiring immediate transfer to the OR. These patients present to the EDs of 2 level 1 trauma centers in the US. One of the trauma centers was supervised solely by trauma surgeons and the other by EM physicians and trauma surgeons, which kind of represents the 2 common trauma center formats. So there were 111 patients, what they called the plus group. This is the plus is point of care limited ultrasound is the same thing as a FAST exam. So 111 in the FAST group, 106 in the control, or 217 patients total. They include adult and pediatric patients who sustained blunt and or penetrating trauma. Mean age of the patients is 27 years in both groups, and patients came from a moderate to high acuity population. 174 of the 217 were admitted. 63 of the 217 went to the OR and 9 died. Secondary outcome measures were CT use, hospital length of stay, and complication rates like hemorrhagic or septic shock, multi-system organ failure, and death. And they also looked at hospital charges. Those performing the FAST were sonographers. It was unclear for me reading the paper if they were like MDs or like RDMS degree techs, but they were trained by a FAST director at the center using a curriculum published by ASIP at the time. The time from ED arrival to transfer to the OR, they found was an average of 57 minutes for the FAST group and 166 minutes for controls. Patients in the FAST group who required OR intervention were transferred in 64% less time than controls needing operative care. This suggests that the FAST exam might speed up time to operative intervention. So as far as their secondary outcome measure results, patients in the FAST group had an odds ratio of 0.16 compared to controls to undergo CT, so they were less likely to be radiated. FAST patients that went to the OR compared with controls in terms of CT use had an odds ratio of 0.07. Among patients admitted, the FAST group spent an average of 6.2 days in the hospital, and controls spent an average of 10.2. And then the authors' regression model showed a 27% reduction in length of stay for the FAST group. Both FAST and controls that went to the OR had longer stays in the hospital, which makes sense, but the FAST patients still had a shorter length of stay on average. The overall complication rate was lower in the FAST group with an odds ratio of 0.27 compared to controls. Additionally, for patients who went to the OR, complications were less for the FAST group with an odds ratio of 0.17 compared to control. Among all study patients, total charges were less for the FAST patients as well, who were on average charged $16,000 compared to controls who averaged $31,000. And then the authors showed a 35% reduction in bill charges associated with the FAST group. There may have been some bias in the study towards a more like rapid provision of care for patients in the FAST group, as physicians weren't blinded to the patient's group assignment or were required to integrate FAST findings into their decision-making process. There may also have been some things confounding the lengths of stay, complications, and total charges that they didn't measure. Regardless, these results were very clinically relevant, as also like statistically significant. Early definitive care has a lot of downstream benefits, including more efficient resource use, decreased morbidity, less radiation patients, shorter length of stay, and less cost to the healthcare system. And this is kind of like intuitive stuff that makes sense. The study and others like it was able to put some actual data behind it and suggest that the FAST exam can potentially help trauma centers achieve these things, including providing better care for patients. That's it. Hopefully learned something from this. Or there were some things I left out, but yeah, these are my references. Any questions or comments?
from what you read, what's your understanding about the use of it in penetrating trauma versus lung?
Yeah, so when I was reading for this, I did not come across a lot of stuff about penetrating trauma. It's just like, I just know that in penetrating trauma, like you should just look at the thorax first for pneumothoraces, look at the pericardium through a tamponade. It didn't seem like it was like, I guess, super helpful for like abdominal, looking for abdominal injury, free fluid, but I don't know.
Yeah, so that's what really want to take home message, and we want to make sure people have this penetrating trauma, it shifts. So the fat is no longer like that useful to see the free fluid in the belly, it doesn't really matter that much. Really what you're looking for is intervenable pathology early in the ER before they go to the OR. So when I see the penetrating trauma scans saved and they're just doing regular pass, I cringe a little bit because you really have to think differently. If there's a bullet going through somewhere, you're saying, do they need a chest tube before they go to the OR? Do they need a thoracotomy because they're filling, pericardial space up with blood before they go to the OR? It's a different frame of reference. So penetrating trauma, you have to think lungs and heart, and then if you want to look in the belly for amusement value later or educational value, you can, but that's not changing anything. Whereas lungs and heart, 100% right off the bat. Whereas one trauma, that's where you fall back in this research that it's tied to whether stable or unstable. And then the last point I just wanted to highlight is thinking through fast exam, like lots of ultrasound, it's not casting. It's not this is negative, this is positive. You have to think about in terms of how it was done and who did I do this with or to. Was that patient sitting upright when they came in? Okay, well, that pneumothorax, did you? And thinking through how much of that lung is above that clavicle. Okay, so maybe there's still room for error and I haven't completely with that pneumothorax in that patient. Is that patient completely stable? They stub their toe. Okay, well, even if they're stable, the sensitivity of this is not that great. Whereas that patient is hypotensive, it's a different patient than doing the past exam too. They're hypotensive, and that's included in the belly somewhere else. One of my favorite cases from a couple of years ago was polytrauma, and that's where a lot of ultrasound is great utility. Polytrauma, a couple of big serious car accidents, and that's strap rather, and both hypotensive, one fluid in the belly. Okay, following that algorithm, went to the OR, great. The other one, hypotensive, no, that's completely negative. All right, there's a pelvic fracture, so there's different suspicion, and that's a situation where we have resource utilization issues. Seeing that negative fast, and the key has said, okay, call our IR department, get this person to IR and close the OR, and that was a big retroperitoneal bleed that they had to work with embolization, and if they would have gone to the OR, the chance it would have been delayed because they didn't have an OR available, and then it would have much worse outcome with triaging appropriately. So just a couple examples I've used.
Do you know if there's any data surrounding this in patients who are maybe altered or intoxicated? I'm just thinking of the patient we had who really had evidence of head trauma, and we ended up hand scanning the patient despite the fact that he was waiting for CAT scan for a long time, which delayed his stay in CT, despite having a negative eFAST, I scanned him.
Right. So I'm guessing they're normotensive, right?
I'm sorry.
They're normotensive.
They were normotensive, yeah. That was completely normal, just intoxicated. That's all.
So then you think sensitivity fast would get great. However, how do people use that in hospitals such as ones you choose to work in, where they probably have to wait a while for their CAT scan?
Right.
You're trying to triage and figure out who goes first. If that exact same patient, you have what looks to be 2 or 2 years of blood in the belly, they're probably going to go to the top of the line. If you're a push hard to get that patient CAT scan, you might even start working blood products before you go to CAT scan because of what you're seeing.
Got it. So it wouldn't change your decision to scan or not scan, but maybe prioritize.
Yeah, and so they're effectively saying they're triage.
Serial fast.
Real fast.
It's better than what?
It is. Yeah, exactly. And
ultrasound's dynamic.
at some level, I can discourage residents from doing fast exams to people who evidence doesn't support too much. So it's completely normal vital signs. Well, the viscous injury or anything else, you have to push for better imaging. And feel falsely comforted by serial normal exam or serial normal down. As far as the data about triaging people towards a theory of observation with serial pass and discharge, a good point to try to find on that.
Yeah, I think just the point is that if you're looking at one data point, too. I don't know the data very well, but it makes sense if you're gonna do one fast exam with somebody, it's like, just like any case.
Sure, okay.
It's the same idea. So even if you're gonna CT first, but doing another one, if the person's waiting a long time, do one and then do another one, that's patient dynamic, just like we're talking about. You're doing like the same idea of doing the CT. Okay, let's take a 2-minute stretch, get the mat set up.
Since we have a little break, can I say something since we're on the conversation of fast?
Of course.
Okay, so just speaking logistics of the fast, I do recommend at least practicing the fast on some of your low risk trauma patients, not in terms of your decision making, but just to get comfortable actually doing the scans. Because we've all been in that situation where the EM attending, the trauma attending, yelling at us, what's the fast, what's the fast? So if you get comfortable getting the views in like low risk patients, then when it actually comes down to a trauma patient, you'll be better at them and do it quicker. So just a push, especially if the volume is down or it's a slow shift, to just practice your fast exam.
I think it's a good point. It's like all of medicine and physical exams. You want to see a lot of negatives, and then you'll be ready to know what a positive looks like.